Interventions to promote comfort. Comfort is a state of physical ease and freedom from pain or constraints. Remember, when you're assessing pain, you're looking at it as the fifth vital sign. You want to take a history using the PQRST acronym, where P looks at precipitating factors, Q looks at quality of the pain, R looks at is there any radiation, what region are you having this pain, S assesses for severity, and T, what is the timing, when does this pain occur, what's the duration. So what are potential responses to pain? Pain makes an individual to be alert to threats. His mind is preoccupied with this painful stimulus because there's an increased blood flow to brain and muscles, because the heart rate increases, the blood pressure increases. There's also increased oxygen supply to brain and muscles because you have these rapid, irregular respirations. He also has an increased visual perception of threats. He's looking out for these threats. He's alert visually because there's increased eye accommodation to light. So he's trying to visualize this threat, where it could be coming from and all of that. There's also removal of excess body heat through increased perspiration. The musculoskeletal system is ready for rapid movement, activity, or responsiveness because of this increased muscle tension that leads to increased neuromuscular activity. There's altered metabolic processes as his GI motility is altered, and you can notice the patient responding with nausea and vomiting. Again, there's apprehension, irritability, and anxiety. And the client begins to verbalize his pain. These are like a communication of suffering and pleas for help. So he's mentally alert to these threats. So those are potential responses to pain. Remember, pain is whatever the person says it is, and it exists whenever the person says it does. Pain could be acute or chronic. With acute pain, it could last from a split second to about 6 months, causing vital sign changes, diaphoresis, decreased healing. Or it could be chronic, where it has lasted for 6 months or longer. You would notice the patient is depressed, there's weight gain, there's immobility, there's fatigue. And what factors influence how the patient perceives pain? An individual's responses or reaction to pain are generally dependent on what is expected and accepted in his or her culture. So culture is one major factor. And again, his past experiences with pain would generally make the individual more sensitive to the pain experience. So what is your plan of care for your patient in pain? Remember, we could have potential nursing diagnosis of acute or chronic pain. There could be activity intolerance. There could be social isolation, imbalanced nutrition, less than body requirement. So first, we want to establish a therapeutic relationship with this client. So we want to establish a therapeutic relationship with our clients. And how do you want to do that? You want to tell the client you believe what he or she says about his or her pain experience. That would help you trust. Listen and allow the client to verbalize his pain, and allow the client to use his own words in describing his pain experience. So again, we also want to establish a 24-hour pain profile. What's the location of this pain? Is it external or internal, or both external and internal? What area of the body is affected? We want to look at the character and intensity of the pain. Is it acute or chronic? Is it mild or severe? What is the onset? Does it have a sudden onset or an insidious onset? What's the duration? What are precipitating factors? So we want to identify alleviating or aggravating factors to this pain. Also, you want to teach the client about pain and pain relief. So explain quality and location of impending pain. Example, before an uncomfortable procedure, you want to tell him about the kind of pain that is expected. You want to help the client learn how to use slow, rhythmic breathing to promote relaxation. Again, explain effects of analgesics and the benefits of preventive approach. Demonstrate splinting techniques that could help reduce pain. For example, a patient who has gone to surgery, abdominal surgery, pain might not allow him to breathe normally. So you want to help him, teach him how to splint the area that will help reduce pain and will help your patient breathe as he should. So again, want to reduce anxiety and fears by giving reassurance, offering distraction from this pain, even by spending time with your clients, that would help to relieve anxiety and fears. Again, you also want to provide comfort measures, such as proper positioning. You can nurse your client in a cool, well-ventilated, quiet room. You can even offer back rubs. And again, you can allow client to rest as he should. In terms of pain medications we can administer, we always want to use a preventive approach. So if pain is expected to occur throughout most of a 24-hour period, it's preferable to have a regular schedule than giving medication as the need arises. Usually, when you use preventive approach, it takes a smaller dose to alleviate mild pain or prevent occurrence of pain. And pain relief is more complete. And you will notice the client will spend fewer hours in pain. It also helps to prevent addiction. Again, you will need a PCA, which is a client-controlled analgesia pump. So this is our PCA over here, and you can see the patient is controlling it with this button. So it's a portable device that delivers predetermined dosage of intravenous narcotics. For example, you can set the machine at a dose of 1 milligram morphine with a lockout interval of 5 to 10, 15 minutes. So it would give 1 milligram and it won't give again until after maybe 15 minutes. So that's our lockout interval. And you can set it for a total possible dose. So we can say, okay, give 1 milligram every 15 minutes for a total possible dose of 5 milligram every hour. So it won't go past this 5 milligram per hour, irrespective of how many times the patient depresses the button. Also, we can use non-opioid analgesics, such as acetaminophen. We could also use non-steroidal anti-inflammatory drugs like aspirin, Celecoxib, which is our Celebrex, even diclofenac. Those are NSAIDs. We could also use opioids. Remember, opioids bind to opioid receptors in the brain, in the spinal cord, and other areas of the body. And they tell your brain you are not in pain. So some examples are our codeine, fentanyl, you'll see a brand name of Fentora, or hydrocodone. You could see in the NCLEX, so hydro-ER, so that tells you that it's hydrocodone, which is an opioid. You could see hydrocodone acetaminophen, which is Vicodin. We could also see hydromorph, which is dilaudid. There's also meperidine or Demerol. So those are your opioids analgesics. We could also use anticonvulsants. Usually, these are used for the treatment of neuropathic pain. We could also use alpha-2 adrenergics, which are used for treatment of acute, either intra and post-operative, as well as chronic, for example, neuropathic pain. Some of examples of the alpha-2 adrenergics are your clonidine, your tizanidine, So those are some examples of our alpha-2 adrenergics. Other methods of pain relief include neurectomy or sympathectomy. A neurectomy is a type of nerve block involving the severing or removal of a nerve, while a sympathectomy is an irreversible procedure during which at least one sympathetic ganglion is removed. So you remember that your sympathetic nerves come together outside the spine area in thick networks of nerves called ganglions. So for example, if you have pain in the upper part of the body, you may get pain relief from blocking the stellate ganglion in the neck area. That's how your neurectomy works, or your sympathectomy. For TENS, which is transcutaneous electric nerve stimulation, which you see in a picture to your left, is actually a therapy that uses low voltage electrical current to provide pain relief. So it produces tingling, buzzing sensation in the area of pain. For example, this lady is having back pain, and it's used for chronic and acute pain. So let's look at other complementary and alternative methods of pain control. You could use relaxation techniques, meditation, progressive relaxation, yoga exercises, distraction, guided imagery. So guided imagery is a relaxation technique that involves visualizing positive, peaceful settings like a beach. So that is also that is also a complementary approach to pain control. You could also use herbal remedies, biofeedback, even acupuncture, which is a form of treatment that involves inserting very thin needles through a person's skin at specific points on the body to various depths. And research has shown that it can help relieve pain. We could use heat and cold applications. You could use therapeutic touch, but again, you need to be conscious of cultural factors. Some culture do not allow you, you don't want a male nurse touching a female in some religious settings, so you want to be sure of religious and cultural factors. You could also use massaging, and the last but not the least would be hypnosis. So this is a helpful non-drug therapy to reduce pain in chronic conditions like arthritis and fibromyalgias.